Okay. And MBBS from which college?
MBBS I have done from Maharashtra, sir.
Okay. And you are from this area only originally, parents here only.
I'm from Muzaffarpur.
Okay, that's very good. That's very
Okay.
good.
Sorry for the error. Somehow was not able to connect. Thank you. Thank you to all the guests.
Parijat has come. Parijat has come.
Yes, Dr. Pranav sir also come. So today I'll show you a short video,
Whatever suits the boss best, that's the best.
please. And this is a young boy who came with blunt trauma. And what you can see is that the anterior capsule is ruptured. And this is all soft lens matter. The lens has become cataractous. So in many of these cases, we actually don't know the status of the posterior capsule. So one has to keep that in mind, that we may need to do vitrectomy. So those instrumentations must always be kept ready.
Foreign body ruled out, intraocular.
No, this was a blunt trauma.
Blunt trauma. Okay.
Blunt trauma.
Okay.
With a ball. With a blunt trauma with a ball. I've very rare to see the anterior capsule rupture like this with a blunt trauma.
That's the reason I asked you.
Yes. There is no corneal wound. You can see there is no penetrating injury anywhere. Oops, no, there is a penetrating injury here. Sorry. This is a hypodermic needle injury. Sorry. This is a hypodermic needle injury. You can see that this is the opacity here. This wasn't blunt trauma.
I have also come across few injuries like this. The globe has been intact, the cornea has been intact.
Yes.
A blunt injury by a tennis ball or a cricket ball, and the anterior capsule has ruptured with a secondary cataract, secondary glaucoma.
Yes. No, but this patient had this. You can see this corneal opacity here, a small one.
Yes.
So here, basically, all we need to do is use irrigation aspiration and remove this soft lens matter. The only catch is, as I said, that if there is a posterior capsular dehiscence, then one may need to do a anterior vitrectomy. And
can you make out posterior capsular dehiscence before the surgery? Do a ultrasound, some kind of indication that can have whether the posterior capsule is intact or not, the zonules are intact or not. Anything which can be done preoperatively?
Yes.
Such cases.
If you
it cannot be 100% foolproof, but some indication to the fact that everything is all right.
Yes, you can do a B scan. And a B scan, if the anterior capsule, if the posterior capsule is ruptured, and if some amount of lens matter has gone behind into the
vitreous, into the vitreous.
So you will have those opacities or echoes just behind the lens, just behind the lens.
Yes. Yeah.
So that would give you an indication that the posterior capsule also has been, there is a dehiscence.
But you know, because once there is injury, and then if you don't do immersion bath, then with the scan, in ultrasound B scan, it is difficult to get the posterior capsule clarity. So then that just a penetration or puncture will not be possible. Unless you anti-segment OCT, that's different issue. Otherwise, it's not possible. But if you get
is it possible with the anterior segment OCT with this kind of cataract?
Yes. Anti-segment OCT
it should not be able to pick up, and penetration of the optical, the light waves probably may not go to that extent.
I don't have any personal experience cataract situation, but it shows. I don't remember which cases it was, but it shows.
Posterior polar cataract, it has shown. I mean, I've done lot in the posterior polar cataracts, the optical OCT.
Mhm.
But when the cataract gets dense, even the posterior polar cataract gets dense, it becomes very difficult to catch the posterior capsule.
Yes, yes.
Okay.
Yes. Nowadays, the recent anterior segment OCTs, which give you, limbus to limbus with corneal scan as well as the lens scan, they are
That's
now.
the thing I've seen, but I'm not sure that, as you said, that if the cataract density is more, you
Yes.
might miss it. I don't know that particular point.
Yes.
But without doing a routine ruling out intraocular metallic foreign body, is it right to go ahead?
No, this was as I said, a hypodermic needle injury. You can see this is the point of entry of the hypodermic needle.
That is the history.
The history is of trauma, and this puncture kind of thing on the cornea is because of the needle.
Shalabh, what sir is saying, I think I agree to it, that one should always be ensure the fact that the metallic body is not in the vitreous in these kind of
Shalabh,
to
in
be
our practice,
medical legally to
we
be
don't
on the
have
safe side.
a negative X-ray, and we go ahead, and if there is something going wrong, then we are in a very slippery wicket. So that's the technicality.
Yes, if the history, many a times the child does not give you a correct history.
Correct history,
Yes.
If because
Mhm.
he is scared, or if the child is too small, then you may not get a correct history. That is very true. And in those cases, I believe you are correct. One needs to do a B scan, and one needs to do even an X-ray, a
So,
simple X-ray.
like
A simple X-ray
to know
works.
that after 55 or 60, pre-op ECG is a kind of must with our CFA around. So that in the same way, I can say.
Yes, yes. So this was, loading the 3-piece intraocular lens.
We're not seeing, nothing is visible. Acha, acha. Okay, okay.
Yeah.
Okay. That area little got hazy.
So the reason I'm putting in a 3-piece lens is because long-term stability of the intraocular lens with this kind of opened, a kind of, iatrogenic, not iatrogenic, a post-traumatic Argentinian flag sign kind of picture. It's better to put in a 3-piece lens with the haptics sitting on the two sides of the capsular bag where the capsular bag is intact. So this is implanting the 3-piece intraocular lens. Is slightly tricky.
Dr. Sala, one thing always comes to my mind. I mean, is there really a difference between a 3-piece lens and a single-piece lens? Because 3-piece lens, inserting a 3-piece lens, the unfolding inside the eye is slightly tricky.
Yes.
Whereas the unfolding of a single-piece lens is more predictable.
Yes.
You are right. So the unfolding of a 3-piece is very tricky. Whenever we try to put it in a pediatric, it usually have to turn it again, and then there is very little space there.
Yes, you're correct in that point, sir. But here, in this case, I was not sure whether the posterior capsule was intact or not. And that is the reason why I ordered a 3-piece lens. Because if at all I had to put it in the sulcus, then I would have had it. Otherwise,
I mean, the query is for the sulcus also. Whether it really makes a difference, a 3-piece and a single piece, if you put it in the sulcus.
No, there is
In the
a
long term?
difference in the sense that single piece will not have that angulation. So like he will put the haptics into the sulcus, optic into the bag. So that will really not be very practical or easy.
But
that is number one.
even
And
the 3-piece
sulcus is more
nowadays
inside.
they have a 0-degree angulation, sir.
0-degree angulation, that's difficult to make that angle into the bag and outside.
No, I don't think the angle is what is important. It is the
Important.
thickness of
It
the
is
haptic.
It is of the haptic, the size of the haptic, the area of the haptic which is rubbing against the iris.
Yes.
which can lead to a chronic inflammation, arthritis. I mean, this is the basic pathophysiology, what
Yes.
people have
Yes.
explained.
Yes. So it
I-
used to
I
happen
have
more with
to
the
limited
Acrosoft
experience-
lenses.
To my limited experience, I have put in the single piece lenses in the sulcus. To this date, I have not found the kind of inflammation that people have been talking about.
Yes, that I will agree with
But
you.
what I
don't. Even
what
I
I
haven't
do,
found it. I haven't found it.
whenever accidentally I have to put that, I put them on an NSID for a longer period of time, 3 months, 4 months, like that.
Okay. Yeah,
No,
so
is it possible that you were lucky to have that sulcus distance matching the distance of the single piece? Because the multi-piece is little bigger. That's the only thing. If it
Maybe.
is fitting, fine. Not fitting, it will have a wiper effect. So you cannot predict. But if there is a bigger thing, it will be fitted in one place only.
Yeah,
Chances
right,
of
right.
creeping, that's the reason, nothing else.
yes,
And in other way, the people are talking that hydrophilic bad, hydrophobic good, but there is a big but.
so here we've put in the lens and I've put air in the anterior chamber. And since this is a young boy, he's going to be active, playing here and there. So I have decided to put in a suture. So this is just to be on the safer side, because this is a slightly larger incision. It's more than 3.2. It's almost 3.4 or 3.5.
Yeah.
These three-piece lenses from Orolab, they don't go in that easily with a 2.8 or a 3.2 also. So
Whatever incision pediatric cataract must be stitched.
must be
Yeah,
sutured.
yeah, that is what I was going to point out also.
Whatever
Any
incision
all
pediatric
pediatric
cataract
cataracts
must be
and
stitched.
all these kind of traumatic cataracts, they should be stitched.
Stitched.
Without trauma also, even your planned child
No.
surgery, it should be stitched
Yeah,
for
yes, sir.
protection.
Yes, sir.
Yes. So that is something that we must always keep in mind, that make sure you suture the main wound at least. If the side ports are leaking, you can suture the side ports as well. But at least the main wound should be sutured or secured.
What's the age
Shalom,
of the
I
child?
say it should always be. I mean, insist on the fact that it should always be sutured.
Always sutured.
Yeah, it
What's
should
the age
always
of the
be.
child? What's the age of the child?
He's about 11 years.
Okay.
11
And
years.
the power calculations and the IOL is the same or different?
No, it's the
It
same.
has to be slightly different.
Beyond
Under correction.
beyond 8 years, I don't think it makes too much of a difference.
And that's what you did. That's the basically now it's a case presentation. So your
Yeah,
plan
so
that we
the-
learn.
No, the intraocular lens was what is done with your routine cases. There was no change made to the power of the intraocular lens. There was no
There is a table which is available online in which you can calculate how much of under correction is required for a 1-year child, for a 2-year child, like that, for a 6-year child.
Yes,
Like,
sir.
like
So
between,
till about 5 years, you have to undercorrect. But beyond 5
I
years,
think,
I
I
would
think,
say
yeah,
don't.
I think it is something like 8 years, because I last week I operated upon a child who was 6-year-old. I just looked into the table which is available online, that said you undercorrected by 2 to 3 diopters. So that was a 7-year child. The 7-year age bracket, they wanted that that list was there. They had given a table which said that it should be undercorrected by 2 to 3 diopters. The child had a power of around 29 plus 29, so I put in a lens of 26.
Now with the onset of pandemic of myopia, our all old learning and teaching will be gone. So
Yeah, true.
where we will stand in few years' time.
Yeah, that's true. I think we are going to become like Singapore.
We'll be Japanese, Japs. No, I saw in any of these meetings, like nowadays, this election meetings, and the children, some came and all those things, and I think 70% children are wearing specs.
Yes, they are.
So So it's a very, very bad thing and we can't help.
So I think I cut the suture. I have to go back and suture it again.
You are lucky there are no posterior capsule tears and needle was good enough to challenge you, but didn't defeat you.
Sir, his VR skills would have come into play had there been a PCI rupture, sir.
If you remember earlier days, only the VR surgeons were phaco surgeons. Means others were phaco machine surgeons. When in
So
my
what I
lectures,
personally feel, all vitreoretinal surgeons have an advantage in doing phaco surgery.
no, at the beginning,
It was in the past.
when
It was in
yes.
the past.
Now you don't get exclusive VR surgeons. You get VR plus phaco.
The only advantage that we people like us who are doing anterior segment surgery, that we are doing anterior segment surgery to such an extent that we have refined ourselves that we do not get into a problem where the vitreoretinal surgeon is called. Only at times, very few occasions. So that is what advantage we have gained out of
No,
experience.
what happened since mid 80s to late 90s, till the phaco machines were improved to an extent that were reliable. Till that time, it was the VR surgeons were the phaco surgeons, others were phaco machine surgeons. VR surgeons used
Yeah.
to help them and they used to talk to the patients. That was the thing in those era, in 80s and 90s.
Oh, 80s and 90s, I think we were still struggling with doing intraocular lens implants, not phaco.
No, it was late 80s. It was late 80s, and then the phaco, and then the small incision.
Right.
Now the
Blumenthal.
anterior segment surgeons, they have become very good, very proficient in anterior vitrectomy also. So 90% of the problems they can solve themselves. I think Shala will give more clue to the fact, more information as to how much of a nucleus drop he gets now than what he used to get 15, 20 years back.
Very few, very few. I think it was in a year we would get, 5 to 10 when I started off in my VR practice. Started going down, down, down. And I think now once in a
Rare.
once
Once in a blue moon.
1 or 2
Once in a
years.
blue moon, you can.
Yes, once in a 1 or 2 years. And that is partly because of course the machines have improved, but also I think the surgeons have improved their skills.
Still, that has both things have improved. The
Both,
experience
yes,
has gone up. The machines have gone up, have improved.
become better.
So
have
it's a combination of both.
Both of them, yes, very true. Very true. I think
I-
machines nowadays are, the chances of creating complications because of the machine is less. Once you're able to understand your machine and, work with the optimal settings, the chances of creating complications has really gone down. But yes,
Other reason is that knowledge is more in the air now. Now everything is available to learn very easily.
if I'm remembering my earlier days, that time there was storage machine, and storage machine was Venturi based.
Sir,
And
I also started with a storage machine, sir.
the
2001,
storage
I
machine was
started
Venturi
Seco.
based. So if you have
Yeah.
not done regular vitrectomy as a vitreoretinal person, so the people who had storage machine, they landed in more problem because it's a Venturi pump. It's very good, but it was psychological block. And all the great teachers at that time were talking, it's a peristaltic pump, and they were creating more problem. So it was delayed for about 5-7 years. Till that time, all that wound burn, this, that, umpteen complications came. And earlier it was ABK, then this became PBK. So the PBK era started. And then this drop started. But till the machines developed this cold phaco and these control things, then only it became smooth. And that took about 12 to 15 years.
yeah, so that is a part of the evolution of any
Yes.
any procedure. any procedure has to go through that period of evolution. There are going to be certain milestones of complications as well. So I mean, I've heard that at one point of time, the intraocular lens was almost banned in the US. Was almost going to be banned in the US till the viscoelastics came along. There were no viscoelastics. I have seen people implanting intraocular lens under air without the use of viscoelastic. So I think every procedure has gone through that period of evolution.
Hello. One more query. I mean, this is also in my mind. A lot of people implant the intraocular lens with the irrigating fluid without the viscoelastic.
Yes.
So how safe that is? Because I have not done it myself because of fear that I just want to protect even one endothelial cell with a viscoelastic. That is the only reason why I have not implanted
So
under
those who have
irrigation.
those who have to do 100 cases in a day,
No. That is not an excuse. No. If you are
No,
doing
but
a surgery
that-
for that
that-
particular
no,
person,
the
that eye
reason
is the only eye for that particular person. That should not be an excuse.
Yeah, but
You
the
should-
first study that I am aware of, where the surgeon showed that there is hardly any difference between the viscoelastic endothelial cell loss, and if you're putting in the intraocular lens through the irrigating fluid, there is hardly any difference, was from Chitrakoot. And Chitrakoot, as you
Let's
know,
put this.
does a high volume surgery. So I think the
Yes,
only reason why they were doing it there was because they were trying to save time. And I would
It is
And
what I've
cost,
heard
of viscoelastic,
Shalab,
cost also.
to prevent post-operative
Shalab,
IOP surge.
no, if
No, that
Shalab.
you wash the
if I
visco from behind the lens,
My argument is the surgery has to be safe in an average hand. There are hundreds and thousands of surgeons who are doing surgery, intraocular surgery. So what is the best and what is the most optimum procedure that should be practiced and that should be followed? I mean, one or two exceptional surgeons can do whatever they like. They can
no,
come out.
Dr. Pranab, suppose you
That is another aspect.
Dr. Pranav, suppose you do viscoelastic and then you are bound to clear the viscoelastic from the bag behind the IOL.
Yeah.
From the bag behind the IOL.
yes,
And
yes.
that's not a very, very smooth thing. Whether you are doing 2 case or 20 case, it is difficult. And you are saying that for average surgeon, he did a good surgery and then he has to take out that viscoelastic, he will not be able to manage it properly. That causes more, he goes in and out and causes more endothelial damage. But if he has done phaco, he left hand or right hand, whatever, he has irrigating thing and he was doing all the things. So he just have to he take the phaco tip away and take the IOL in the hand and it remains same pressurized as it is. He can put on continuous irrigation. Endothelium is fully safe.
No. The study that came from Chitrakoot showed greater endothelial cell loss with the irrigating fluid on and putting in the intraocular lens versus putting in viscoelastic and then putting in your lens and then doing irrigation aspiration. There was a difference, but they said that it was hardly significant. That the statistics showed that it was hardly significant, but the amount of endothelial cell loss was greater with the fluid only.
That's a training institute. Salab, that's a training institute.
Sir,
So that
when
is
I
why-
started doing when I started doing IOLs, ECC IOL, that was way back in 95. I used to put it under there. That practice, because I was trained in Madurai, and Madurai people, they used to implant the IOL under there. So for quite some years, I was putting it under there till I found out the viscoelastic, the difference between a viscoelastic, and there was a difference. I could not study the endothelial cell loss, but clinically there appeared to be a difference. So that is the reason why I have got a mental block to the fact that I'm not doing it under irrigation.
You do it under irrigation, you'll see the next day the cornea is better clear than your viscoelastic.
I'll try that. I'll try one day. Tomorrow I'll try. One case I'll try tomorrow.
Not one case, you have to do 10 cases to know the things. In one case, you are blocked mentally.
I don't do
After
more than
3
6
cases,
cases a day. So I have a limit, quota limit now because of my age. 6 is my limit. I don't go beyond that.
Yeah, I mean, for surgeons like us, who are doing lesser number of surgeries, I don't think we are in a hurry to finish 5 or 6 cases. So I think it's better to use viscoelastic. As sir said, patient ki to wahi hui kaak hai, and we must not take chances. Those who do 100 cases in a day, maybe they
so
they
in
have to
toric
finish
lenses,
faster.
what will do, boss?
Yes, sir.
In toric lenses, what will do? Toric.
Toric also I will implant under viscoelastic. Very well, it goes in
Toric
under
I implanted the
viscoelastic.
viscoelastic. I do a
And
lot of toric.
once you've
I do a
Actually,
lot
you
of
are more
toric.
advanced surgeon, both vitreous and anterior, so for you, no problem. But think of only anti-segment surgeon who has
I
fear
don't
for
think
posterior segment.
No, I don't think there is a very, very difficult thing to do to, pick up your intraocular lens using irrigation. I don't think it's very difficult to do.
There are only
Then,
one case of toric rotation I have found with the viscoelastic in my long experience with torics, nearly 8-9 years. Only one case I had to rotate because of spontaneous rotation. Otherwise, most of them have been more or less
Maybe
stable.
the size of the bag was different, so that is possible because you are not having all the measurements of this data. That is, I understand. But still, it comes that if there is viscoelastic, the chance of spontaneous rotation is little more. And
I think
if you are not
if
100%
the
clearing the
patient is
bag, it
highly
will be
myopic, then there is a chance that the bag is going to be large, big. The rotation may be there with high myopic cases. But with moderate, normal axial length size eyeballs, it should not happen.
yes.
Mm.
So, I mean, it actually depends what works best in your hands. And if you have a specular, for many years I didn't have it. I now have a specular. So now I can, see my patients before and after surgery.
Yeah, that is.
So unless until you have a specular microscope, you can't really comment on what you are doing, whether it's right, wrong, what is the endothelial cell
I mean,
count
just
in
a
your
clinical
hands.
observation you can make. Just a clinical observation you can make.
Yes, the clarity of
First
the
post-operative
cornea
death
or
and yeah, clarity of the
post-operative.
cornea
Yes,
on the slit lamp.
yes,
But
6
specular
hours.
microscope, definitely you can make a study of it, whether which is better.
yes. So, but then you have to do both the things. Implant
Actually,
तुम्हारे पास है तो तुम करो,
yeah,
तुम करके हम लोग को
absolutely.
बताओगे. When you have the advantage, you have a specular microscope, do it and do both procedures and then tell us as to what we should do.
When he will do the first specular after the surgery, you tell him that. When he will do that first surgery, first specular reading.
This first specular should never be done before 3 months, I think.
No,
Because
I'm just now debating. I'm just debating.
Yeah.
3
So
months, 3 months.
no, that's the basic point. If you see the cornea on the slit lamp, and whatever you judge this patient has any endothelial trauma or not. You will see it there, and everything is there. You have learned your clinical medicine; it is all there with you, and you can even see the specular reflections. You know that there is something wrong or not. That much is there. Now the slit lamps are so good, and you have, I think, how much 40 that out of the 5 steps, the highest one. I don't know magnification, but you see almost everything clearly. So that gives us the clinical data, and that will guide us and help us in our clinical judgment. But to put a specular on the cornea after surgery before 2-3 weeks, I will not dare to do. And then everything nature takes care. The first
Specular
6
is
hours,
non-contact.
12 hours, 24 hours.
It's a non-contact. No?
The specular is non-contact.
Non-contact.
Non-contact. Yes. You have come a long way.
So I think shall I do a study on this preoperative,
Actually, sir, I
post-operative,
tried.
both
I'll tell you.
procedures.
I have tried to implant an intraocular lens using just fluid, but the problem is that I load my lenses myself. My assistant doesn't. So if I have to
Even I
implant,
do mine.
if I have to implant an intraocular lens under irrigation, it means that when I finish my phaco, I have to load my lens, then do irrigation aspiration, and then put in the intraocular lens. Now, I have tried to do this, but in one case, the IL got stuck in the cartridge because it was there for such a long time. And the other case, the opening of the lens in viscoelastic is so smooth, but in the fluid, the turbulence of the fluid, doesn't allow it to open naturally. So I think that this is a big risk we take in implanting an intraocular lens under fluid.
I
because
think
of
only the
turbulence.
Icon IQ lens, only the IQ lens may behave properly because the unfolding is reasonably predictable. The
No,
other lenses,
it's
any other company, I
it's
mean, that
because
is
of the
one lens.
turbulence, sir. It's because of the turbulence of the fluid.
Right,
It
right.
has it
Absolutely.
almost has nothing to do with the quality of the intraocular lens. It is the turbulence of the fluid which will not allow it to open naturally like it does under a viscoelastic. So after those
But you
three
have
cases,
viscoelastic in the cartridge. You have viscoelastic in the cartridge.
no, but there's turbulence in the anterior chamber. It's not that little bit of viscoelastic that is going to prevent the turbulence in the anterior chamber. So that
So,
after
but Chalab, tell me how people are so confident. They are advocating almost every high-end surgeons. They are advocating do it under irrigation, do it under irrigation, save a lot of time, this
Yes,
and that. I mean,
high-end surgeons
yes,
have
it is done.
high-end
No, I'm
surgeons
not
have
high-end surgeon. No, I'm not high-end. I'm not a very much doing it. But because what I'm saying that when I
I'm not.
started
I'm not saying about you, sir. But most of the
no,
conferences that we go to, we have that under irrigation. But practically, I'll do it. But I'll do it tomorrow and then get back to you tomorrow.
Intentions of putting an
we are
IOL
almost
and
going to
putting an
finish.
Indian lens.
We are almost going to finish.
No.
Let's say good night. Good night. Thank you. Sorry for the
Okay,
delay.
good night.
Sorry for the
No,
delay.
that was an